You all set, Joe?
I'm good.
All right. Welcome, everyone. We'd like to welcome you to our our webinar series. This is, I believe, now our, I'm going to say 9th webinar. And today we're joined again by Dr. Minichiello. He's the chief resident in the ED and will be our EMS fellow come this July. So congratulations to you, Joe. Today he will be discussing diabetes and DKA and drugs. Joe.
Perfect. Thanks, Eric. So it's tough to be fully interactive over a webinar. There'll be a couple of points, though. I'll just look to get people's thoughts, so you can drop thoughts in the chat. There's both the chat and the Q&A that we'll monitor kind of as we go through, so please ask questions as we go as well. But here we go. So when I first kind of made this talk, I mean, we want to cover core topics as we go through this and some interesting things. So the hope is that this talk has both a combo of core content for diabetes with some kind of interesting tidbits to add in there too. And if anyone's an Office fan, when I came up with this diabetes DKA drugs, it just made me think of Dwight Schrute saying Bears beats Battlestar Galactica. So little Office reference. There's my pop culture for the day. All right, I have no financial disclosures, but if anyone wants to send me some extra cash, by all means, I'll give you my Venmo. Our objectives for today, so a couple pieces. We're just going to define what diabetes actually is, just a little quick view of diabetes across history, talk about the actual pathophysiology as well as the epidemiology of diabetes, just be familiar with some of the devices that are used in diabetes management, both for patients as well as what we use ourselves, look at a couple of cases and apply some skills to actual diabetic emergency treatment, and then kind of throughout looking at some drugs, medications that get played in and some extra considerations to give for folks who are on those medications.
Hey, Joe, are you advancing your slides?
I am.
Just want to, I'm still showing the webinar will begin soon on this side.
Let's see. What is it currently? All right, stop share, reshare. Share this. Do you currently see objectives?
I do.
Okay, let's go to the next slide and see if these work. These are the things I all just said to you out loud. That advanced?
There you are, sir.
Sweet. A little refresh is all it takes sometimes. When in doubt, turn it off and turn it back on again. So 2 patients, just to be thinking in the back of your mind as we kind of go through here. As we eventually we'll get to DKA. 2 different patients that you could be easily called to, folks that we may see on a daily basis. One, you have a 25-year-old male who has known type 1 diabetes, is thirsty, has a dry mouth, is sleepy, these rapid deep respirations, and your glucometer reads high. You have a second patient who has a history of type 2 diabetes, but similar symptoms, thirsty, dry mouth, somnolent, these rapid deep respirations, and their sugar is 150. I want you to kind of a little pre-test for yourself, think which of these folks might have DKA, how do these folks get DKA, do both of them have it, is it just one, and we'll explore that as we go here. So what is diabetes? And really today we're talking about diabetes mellitus. So there are 2 types of diabetes. There's also diabetes insipidus, which is a whole different talk that has to do with neurologic things and the kidneys. But diabetes itself, what does it actually mean? Really, it comes down to sweet urine. And so diabetes, coming from ancient Greek, talks about a large discharge of urine. Multiple thousands of years ago is when diabetes was really first being described as these folks that were having lots and lots of urine, and then they seemed to die after they were having lots and lots of urine. And then at some point along the way, someone decided to use the Latin word mellitus, meaning honey sweet, in Latin to then describe the fact that there was sweet urine in these folks. First noticed by ants kind of going all towards the urine from these folks. And then there's some other testing. Really, though, the Egyptians first described this about 3,000 years ago. Then it was being described in some ancient writings from India. They described this condition of madhumea, and I'm probably botching that, but also means honey urine. So multiple cultures across different spaces describing this similar process. The Greeks then described this melting down of the flesh and limbs into the urine. So we'll get a little bit into kind of the muscle wasting and weight loss piece that can play in here. But really, this was being picked up on 2,000 years ago. And at some point in the 1700s, you could have this awesome job of being a water tester. And a water tester's job was to actually taste the urine of patients and try and make diagnoses based off the taste of urine. To the side here is a old urine chart where they used to go off the color and the taste and would then come to a diagnosis based on the color and taste of urine. Let's just say I'm thankful that we have glucometers and that this is not in my job wheelhouse to be a water tester. It wasn't until the late 1800s that people first really understood that the pancreas was involved in folks that had diabetes. Wasn't quite sure of the connection, but was noted that people that had pancreas injuries seemed to have diabetes. Then early 1900s was the first time that insulin was established as playing in here. 1920 was the first time that insulin was isolated and then used as a treatment for folks with diabetes. And then in 1923 is when the insulin patent was sold. And these were three guys with the last names Banting, Best, and McLeod. And from the history book piece, just for a nominal symbolic fee, they sold the patent for insulin for a single dollar each. And if we then, without getting all into politics today, if you look at where insulin has come today, it is not at all in line with what Banting, Best, and McLeod wanted. They wanted the patent to be widely available, and yet now today, insulin is one of the most expensive medications for folks who absolutely need it. So a little bit on the epidemiology. Who has diabetes? I mean, it's something that we encounter every single day in our field. 38.5 million people in the US. This is as of 2021 World Health data that we have these numbers. That's about 10% of the population. That's 1 in 10 people. Certainly, it's a percentage of every single day here in the ED. It's a percentage of every single day in the pre-hospital call setting. Throughout all causes of death, about 7 or 8 top reason for death is related to diabetes. As we get to a DKA, and then it's kind of cousin HHS are really the causes. But diabetes, as we'll also see, can cause heart disease, stroke, lots of downstream problems. Worldwide, a similar percentage, 10%. So lots of people, very prominent. It's a space where then research and funding is important because there are lots of people who benefit from better treatments. It seems to affect males and females roughly equally, affects folks of lower socioeconomic status more. Part of that comes down to nutrition, access to exercise, education, etc. Seems to happen more in non-metro areas, so the more rural you get, and you can kind of look at some of the confounders that might lead to that. And then a few of the different ethnic groups that it seems to affect a little bit more. Types of diabetes. So I throw a couple at you. Type 1 and type 2 are certainly the things that you've probably heard the most. Old school names, type 1 juvenile diabetes, but really type 1 is more about the mechanism. Type 2 is kind of adult onset, but again, it's more about the mechanism. Give a quick nod to this type 1.5 that has come out kind of in the recent medical literature. There's also a type 3, but that is more of a research thing and not really a true diagnosis yet. And we'll give a nod to gestational diabetes here too. But then the actual physiology piece. So what are we talking about? So big picture, you have the endocrine system in the body. When the endocrine system is what regulates all sorts of processes in your body through hormones. Really, though, the one that we care about today is kind of the pancreas, insulin, glucagon balance. So you have some sugar, you eat this lovely cupcake here. Then the sugar stimulates your pancreas, and there are 3 or 4 different types of cells in the pancreas. The 2 that we're going to care about today, so you have these things called beta cells. The beta cells in your pancreas see sugar, and in response to sugar, they release insulin. Insulin is a hormone, so it's something that is released by cells in the body to tell cells in other parts of the body to do something. And so when insulin gets released, insulin goes to places like the liver and says, hey, we got lots of extra sugar around. Let's store this for later. Similar, it goes to the muscles and say, hey, we got extra sugar around. Let's store this for later. It gets stored as glycogen. If you ever heard of us talk about glycogen stores, this is glucose gets converted to glycogen for storage. And then it gets used up in the body. And so the kind of typical set point depends on the book you see, depends when the image was made. This kind of idea of a sugar of 90, really more recent says as low as 70 can be totally normal place to be. The other end of this sort of balanced feedback loop is if you have low blood sugar. It's been a couple hours since your last meal. You've been hit with multiple calls back to back, haven't had a chance to get a snack in. What happens is the alpha cells, one of those other types of cells in the pancreas, sense that there's not enough sugar, so releases glucagon, which is a different hormone, and it's a medication in our regimen and toolbox pre-hospitally. And so glucagon then comes along, tells things like the liver and muscle that they can release that glycogen as glucose to raise glucose levels around the body. So these are the two hormones to keep in mind. This is the overall set point system that should work normally. When this goes wrong is when you can then get something like diabetes. So similar diagram, similar concepts. Just another way of looking. Pancreas gets a sugar signal, releases insulin. Low sugar signal releases glucagon. But the liver and the pancreas are the two big organs that are coming in play here. So some folks that have diseases like a chronic pancreatitis can be prone to having diabetes just because they have breakdown of those cells and it doesn't work as well. People with bad liver disease also can then develop diabetes related to that. We'll look more at those in just a second. All right. So type 1 diabetes, they kind of formally called juvenile diabetes. Type 1 diabetes is an autoimmune disorder. And so you get type 1 diabetes because your immune system attacks those beta cells in your pancreas, and then your body is no longer able to produce its own insulin. And so you are just an insulin deficiency problem, which then means you are insulin dependent. You need insulin from the outside for your body to actually use that sugar, take that sugar up into cells and be used to create energy or be stored for later. This across all cases of diabetes is really, it's the minority. It's only about 5 to 6% of all adult cases. But when you then look in children, it's about 85% of all childhood cases. So much more common for type 1 in kids. That's because of its etiology. We'll look at type 2 in a second and kind of see that type 2 requires more time, more insult to eventually build up to that. But type 1 diabetes, things to keep in the back of your mind. These are folks who are going to have, extra thirst because there's so much sugar in their blood. Their body is going to stimulate and give us water to dilute the sugar. They feel extra hungry because they can't take up the sugar into their cells. And so things like the brain say, I'm not getting enough sugar. So it stimulates hunger. So even though their blood sugar is really high, parts of the body aren't getting sugar and still says, eat more. You get weight loss for that same reason. You can't actually bring that sugar into the cells. So your body can't actually build up muscle or build up fat. You can then get vision changes, feel tired. You have poor wound healing, and part of that is with the sugar being so high, bacteria gets in, and then you also have issues with the vessels themselves. And then you're more prone to yeast infections. And so especially when we see like a young kid come into the ED that has a yeast infection, it's like a big red flag for us to start looking for diabetes as an underlying problem. Type 1.5, just as a quick nod in case you ever have a patient tell you this, it's just something interesting and up and coming. So type 1.5, it's also known as latent autoimmune diabetes. The mechanism of how you get this is similar to type 1 in that it's an autoimmune process. It's the body destroying those beta cells, and so you can't make your own insulin. So you eventually become dependent on insulin. But it presents later in life, usually after the age of 30, and can be into your 40s, 50s, 60s. The symptoms, though, seem to present more like type 2, and that it's not this big kind of sudden onset change. So just something to keep in the back of your mind. You might get this mixed picture. Patients might tell you about it. This is just what it is, just so you know about it. Now, type 2 diabetes. This is the much more prominent process. The mechanism for type 2 diabetes is your body is resistant to insulin. So you still have those beta cells. Your body is still able to make insulin. But the cells over time, and part of this is from damage from having high blood sugar all the time, from having bad vessels, from having high blood pressure, lots of insults across the body make cells around the body more resistant to insulin. And so you have this loop in your body of then needing more insulin to get the same effect. It's almost like you build up a tolerance. If you think about relating this to other medications, your body's becoming more and more tolerant of that insulin and needs higher amounts to still have that same effect. Eventually, this can progress to becoming insulin dependent because your body just can't make enough insulin to actually have the effect that your body needs to then take up that sugar. It is certainly the vast majority of folks across all ages that have diabetes is type 2. And interestingly, about 20% of those folks don't actually know they have diabetes. And so it's not uncommon that you might get someone that calls you for just kind of this general fatigue, weakness, not feeling well. As part of your workup, you check their sugar. Their sugar might be 500 or 600. They come into us and then they don't have a known diagnosis, but we kind of get them on the train of getting their sugar down, getting them in to see their primary, or getting the right referral to then get them on some medication to be able to control this. So just because someone doesn't have the diagnosis known doesn't mean they don't have it. And then there's a big link here in the US between weight and type 2 diabetes. Part of that's just the higher sugar, the poor our diet, less exercise, and then it kind of causes all these effects around the body of being less sensitive to insulin. Gestational diabetes, something worth being aware of, especially in a higher risk population already, being pregnant women. One of the other multiple challenges that can affect women during pregnancy is gestational diabetes. And it's interesting. So part of this starts out as an actual natural mechanism that's good for baby, of moms, pregnant women, develop naturally resistance to insulin so that there's enough sugar still left to then cross the placenta and get to baby. So the idea here is mom has less sugar uptake to then be able to supply sugar to the baby in utero, which is a good thing. The problem, though, is that this can tip over too far and get to the point that mom also isn't able to take up enough sugar and has too much sugar circulating around. One of the things that we watch for, and something to be mindful of if you have an out-of-hospital delivery, is that if the mother notes having gestational diabetes, baby is at a higher risk of developing hypoglycemia immediately after birth, because baby's used to living in this high sugar environment and now is in a world where not exposed to constant sugar and is going to be dependent on mom's feeding. So just if you're in a space where you're delivering a kiddo, it's really important. One of the many details to get from a mom about prenatal history is gestational diabetes, because there is this increased risk. This typically resolves in the postpartum setting. It's the pregnancy, it's the hormones of pregnancy that cause this process for mom. That said, about half of folks that have gestational diabetes will go on later in life to develop type 2 diabetes. The exact link there isn't entirely known yet. We just kind of know that there is that connection. So diabetes in general, why do we care about blood sugar? Really, it's all of the effects that diabetes then have on your body long term. One of the main connections that links a lot of these is vascular disease. So blood sugar over time is really irritating on the blood vessels. It causes calcification, it causes thickening. You just have poor perfusion to lots of different places. One of those places is the coronary arteries, and so there's a higher risk of heart attacks in these folks. And this is sometimes one of the populations where you hear the term silent heart attack due to other pieces of physiology that we don't have time to dive into today. You might not actually get that full crushing chest pain stimulus. So it's kind of the more of the silent heart attack that folks can get due to the disease from diabetes, strokes, kidney disease. This will progress. That there's certainly a number of folks that we have in the ED that I'll bring in or that have dialysis dependence. And so for a lot of folks, they progress to advanced end-stage renal disease with diabetes being the underlying mechanism. There are plenty of other things that cause advanced kidney disease, but diabetes is a huge underlying cause for advanced kidney disease. You get retinopathy, vision changes, blindness, cataracts, lots of effects on the eye. And then you have poor wound healing, kind of as we gave a nod to before, both having the high sugar environment, having poorer vessels, and you're more likely to have infections in those spaces too, because it's a more sugar-rich place that bacteria want to live. Neuropathy, these are the folks that talk about kind of burning in their hands and feet, or their hands and feet might be numb, makes them more at risk for falls, makes them more at risk for wounds on their feet because they can't feel pain of their shoes being uncomfortable or don't feel that they step on something. So it's a great thing to keep in your back pocket if you're ever doing a head-to-toe assessment on someone who may be septic or has a fever, you're not sure why, especially if they have known diabetes. Big thing we always do is take off the shoes, take off the socks, and look at the feet, because it's not uncommon that there's a wound hiding there on you. Hypoglycemia and DKA I have bolded because those are the emergencies that we're going to dive into a little more. But HHS, HHNK, just a nod with that being there. So these are hyperosmolar hyperglycemic syndrome. The NK is non-acidosis ketogenesis. This is a syndrome that's a cousin of DKA, where you still have high sugar and electrolyte problems, but you don't have the acidosis piece. So not a huge pre-hospital piece beyond you identify the high blood sugar and the concerning symptoms, you bring them in. And really, sometimes this diagnosis is hard to make until we actually have the lab data to distinguish it from DKA. All right, hypoglycemic emergencies. So certainly something that we need to be prepared for, something we have multiple resources for. So the most recent protocols, hypoglycemic emergencies to treat, the threshold is now a sugar below 60. Two pieces kind of come with this. We have data that says that with a sugar below the level of 60 is where you'll start to see some of the adrenergic symptoms. So kind of the sweating, might get some tachycardia. And then if the sugar then starts to drop below 50 is then when we tend to think about the CNS effects of the altered mental status, progressing to coma. Certainly, I'm sure most of you folks have seen someone who's hypoglycemic. Oftentimes, one of the textbook things that we always get told to watch out for is the person has their car accident and people just assume they're drunk, but in fact they're hypoglycemic. So blood sugar really has been described to me, and we'll kind of say this multiple times, especially in kids, but any altered patient, your blood sugar is your sixth vital sign. I mean, yes, it's a little prick on the finger, but truly, I think we as a health system in general underutilize it as a tool. It's quite easy to obtain, and it gives you a ton of data. For someone who is able to swallow, PO is absolutely the preferred route for this. But if you don't have someone able to swallow and you have ALS available, getting an IV, if someone has over 40 kilos, protocol talks about giving 25 grams IV. You can get there either with 50 cc's of D50 or 250 cc's of D10. Kind of a general rule of thumb, if you've never seen this before, this applies a little more for kiddos, but can somewhat carry to adults under 40 to 50 kilos. There's this rule of 50, where you can take the formulation of dextrose that you have, multiply it by a cc per kilogram dose, and that'll equal 50. And so your goal is always to get to 50. And so if you have, hospital-wise, we have D5 available, but really we're deciding between D10, D50. D25 doesn't really exist pre-hospitally that I'm aware of. But if you want to give D10, 10 times 5 gets you to 50. So you're thinking 5 cc's per kilo of D10 or 1 cc per kilo of D50. 1 times 50 gets you to your 50. This got a little messed up into the slides. That's okay. If you're ever trying to figure out a rough size for kiddos, if you don't already have this tool down, I love to share this. If you label your fingers kind of based off the year of age of the child, so 1 year old, 3, 5, 7, 9 years old, you can then relate it to a rough body weight. So if you don't have a scale available, if you don't have a Broslow tape right nearby, a rough estimate is that a 1 year old should be 10 kilos, a 3 year old is 15 kilos, and so on. So for kiddos, need a quick reference for body weight. This is a quick, easy tool right on the hand. Continuing on with hypoglycemic, if you don't have an IV available, prefer to not then jump right to the IO. Part of this is if you were to infiltrate and then have your sugar going into the tissues. Sugar is a really caustic thing to go into tissues. So if you don't have an IV immediately available to start some D50 or D10, you can then jump to IM glucagon. The dose per the protocol is based on a 20 kilo cutoff. It's going to be IM either 1 milligram above 20 kilos, half a milligram below. If we think back to this image from earlier, the way glucagon is going to work is glucagon naturally in the body, the pancreas should be stimulated by having not enough sugar around. In this case, glucagon, we're going to give it and just kind of help override or help back up the pancreas. And really, we're trying to tell the liver is the main place, but some of that muscle around the body too, places that have that glycogen built up. We're going to use glucagon to tell the body, hey, break down whatever glycogen we have into sugar and start releasing it. The issue is there are a couple folks, certain populations, folks who have kind of a long-term alcohol use, folks who have cirrhosis, people who just don't have a great nutrition and food intake at baseline, don't really have these glycogen stores built up So you can give them all the glucagon in the world, but there's just nothing to break down. You have to keep in the back of your mind that there are some folks that are not going to respond to glucagon because they don't actually have those stores built up. Regardless of your patient, regardless of the intervention, if they had significant hypoglycemia and you're doing some sort of treatment, you should be checking a sugar every 5 minutes. Sooner if you're seeing recurrent mental status or clinical presentation changes. But having a trend of sugars is great, especially if you have those longer transport times. And then if you get all the way down this pathway, you gave the glucagon, didn't do anything, or is not quite getting your person back to where they should be, still unable to get an IV for whatever reason, at this point in the algorithm, you can then go ahead, put an IO, and give sugar through the IO. Just again, being really mindful that you don't want to infiltrate that IO. The sugar around is going to be quite irritating and caustic to that person. All right, first drug to give a nod to, and this is not, I'll say a little star, this is not in the category of a novel drug, but it's a drug that we absolutely can't ignore when we're talking about safely caring for folks around diabetes. So sulfonylureas, this is an older school class of drug for folks with diabetes. More likely you're going to see this in your folks who are probably 60 years and older, less likely to see these in your folks who are 20 or 30 years old with diabetes. The way sulfonylureas work is they stimulate insulin to be released from those beta cells. So this is not a medication that's going to be used to treat type 1 diabetes because the beta cells don't work. But for folks who have type 2 diabetes, we can give this medication that helps tell the pancreas, hey, release more insulin. A couple names here to be familiar with. Glipizide and gliburide are the generics. Glucotrol and diabeta are some of the brand names, or the two more common ones. Glimepiride, chlorpropamide are also available. There is, in my mind, kind of a list of a dozen or so drugs that I just always keep when I'm scanning a med list to watch for, because it's always going to change what I'm doing and it's going to change how that person looks. On that list for me are things like metoprolol and beta blockers, diltiazem and calcium channel blockers. Metformin, like we'll talk about, gives me a cue about diabetes, but sulfonylureas, honestly, I'd argue, should be on your list of meds to just have a recognition for two reasons. One, for patients who are prescribed the medication, these drugs have a really long half-life and a really long duration of action. Why do we care? Well, in the setting of hypoglycemia, you might have someone who has a sugar of 30 that you just gave some medication to. They feel better and they want to get signed off. Really, absolutely should not sign off this person, though. Glipizide alone is one of the examples, has a half-life of 7 hours. So you may give someone some glucagon, you may give them a 250 bag of D10. They feel great, but this medication is going to hang around much longer than whatever medication you just gave them. So the chance of recurrent or rebound hypoglycemia is very high. So absolutely should be transporting someone if they have this on board. The other thing to keep in mind for sulfonylureas, if you've never heard of this concept of one pill can kill, really this applies to our pediatric population. This is on the list of medications where if kids get curious, kids are staying at grandma's house for the weekend, get into grandma's med box, gets one white tablet in their mouth. If that one white tablet is a sulfonylurea like glipizide, again, that medication hangs around a long time. And kids are super, super sensitive because they've never seen this before. And kids do not have these big stores of glycogen built up. And so you can get really, really dangerous hypoglycemia on these kids. In the hospital, we're checking like every 30-minute sugars on this kid for 24 hours. So this is definitely something to have on your list also for a pediatric ingestion, as absolutely calling poison control and absolutely coming in to see us for some further care. All right, let's get to DKA. So DKA, breaking down the letters, diabetic, keto, acidosis. So the diabetic piece goes back to the blood sugar itself. So you're looking for hyperglycemia. The technical definition for DKA is you have to have a sugar above 200. Things that happen when your blood sugar is that high is you get this osmotic diuresis, meaning there's so much sugar in your blood that there then becomes so much sugar in your urine, and sugar takes water with it. And so there's a lot of peeing that happens. So these folks are really prone to dehydration because they're having so much urination. With that also comes electrolyte depletion because so many electrolytes are being insensibly lost in the urine. And then also when we get into the acidosis piece, As your body starts to drop its pH, you then start to affect some of those proton potassium exchangers around the body. And so you start to shift potassium in and out of cells because there's so much acid shifting in and out of cells. So your electrolytes start to become really wonky. Unfortunately, we don't commonly have eye stats around to know this. It's just something to keep in the back of your mind for these folks, as they are prone to arrhythmias from hyper or hypokalemia, most likely to be hypo, because the potassium is shifting in their cells and they're also losing it from their urine. K, the ketosis piece. So there are a couple ketones that our body naturally makes. The cool thing with ketones is when your body runs out of sugar for things to use, really we're talking about things. We're talking about muscle cells and we're talking about brain cells need constant nutrition. But if there's no glucose around, your body has this really cool process to make these ketones out of breaking down extra fat stores. So we're avoiding the piece about not having glycogen, avoiding the piece about not having glucose, and we're going to make these ketones out of our fat cells instead. The ketones are great because they can cross the blood-brain barrier, so you can get an energy source to the brain still. The issue is these ketones in and of themselves can cause acidosis, and they're a little slightly toxic to the body. So they're a great temporary fix until we can get to our next meal, until we can get more sugar in. But ketosis is a tough place to be. You hear about, keto diets. You just got to be really careful on a keto diet. If you're balanced correctly, keto diets can be great because it's just that. It's the goal is to burn fat to make ketones because there isn't sugar around. But the acidosis piece is where you get dangerous. And really the sign that you're going to see, because again, don't necessarily have an eye stat to run a quick ABG, but if you're looking for a respiratory compensation, and really this is the Kussmaul respirations that you hear in the textbook, the rapid, deep breathing, because your body is trying as hard as it can to blow off as much carbon dioxide, to blow off as much of that acid as possible. And DKA, if not treated correctly, and even if treated correctly, has a pretty high mortality. We're talking like 2 to 5% of people that if they get themselves to DKA, they have a chance of dying. Not just morbidity of some long-stream effects, but actually dying from this. So this is incredibly dangerous. Definitely something to be watchful for. Things to look for. And it's tough because some of these are just like, well, Joe, you told me the symptoms of someone who has diabetes. And yes, it's going to be diabetes, but it's diabetes plus. So extreme thirst, lots of urination. Now you're starting to talk more GI symptoms. Hyperglycemia alone really shouldn't be causing intense GI symptoms with frequent nausea, vomiting, and abdominal pain. Something that you can get, and I swear there are some people that are much, much more sensitive to this than others, is you get that ketone breath. I've worked with people that can just walk into a room and they're like, yep, this is DKA, I know it. Before we even check the sugar, don't even know the person's diabetic, but they can just smell the ketones. They're hypersensitive to it. I'm up close in someone's face, I get it, but I've worked with people that just walk in and they know. And then this rapid deep breathing, that Kussmaul breathing is something else you're watching for. Weight loss is something that might get described, as we talked about before. This is just your body can't take up the sugar, and so you build up losses through that direction. And then altered mental status is a much more concerning feature if you progress to the level of being altered. There's a risk, and this is much more in kids, of developing cerebral edema due to all the shifting that happens, to the extreme that, like in the pediatric ICU, we're giving like hypertonics to kiddos who have DKA that are altered because they have a really high chance of permanent brain damage from DKA. So super, super serious. Do not want to undercut just how worried we are when folks have DKA. So what causes DKA? How do we prevent it? Well, insulin deficiency is a big problem. And so especially if you have someone who's type 1, a couple of ways you get there. One, if they just don't give themselves their insulin, they may have an insulin pump that fails for one of many reasons. Infections can be a trigger that kind of tips over the whole body's physiology. You get some of the just big insults to the body in general, big stressors, STEMIs, strokes, someone who's on steroids. So steroids have an effect where they just raise your blood sugar in general. So folks with diabetes who are on a steroid burst for a disc herniation or steroids for their bronchitis can also throw their diabetes over the edge. So we are really careful when we give folks steroids. So you got to keep in mind how it's going to affect their other diseases. Hyperthyroidism, so folks with Graves' disease and other hyperthyroid processes can have comorbid DKA. There's a whole it'd be interesting for a case presentation at some point. But a couple months ago, we had this really complex kiddo that started out in Stanford and came over here to Portland, who had comorbid thyroid storm and DKA. Really interesting case. Happy to talk more about it. Unfortunately, that in and of itself would take a whole hour. Ethanol can be a trigger. Again, it's just messing with your overall metabolism, physiology, the way your body's using sugar or not sugar. Pregnancy, and this again kind of gets to the gestational diabetes, insulin resistance piece. And then DKA, in terms of a percentage, is much more common to be seen in type 1 diabetes because it's an insulin deficiency problem. And so folks don't have enough insulin. Really, type 1 diabetes is where we can't make it ourselves. You can get deficiency enough in type 2 diabetes to still get DKA. Just because someone's a type 2 diabetic does not mean they can't get DKA. So you still have to keep DKA in the back of your mind. And as we have more and more folks that just are getting diagnosed with type 2 diabetes, even though it's a much, much smaller percentage of folks with type 2 that get DKA, the overall numbers might start to surpass type 1 just due to how the math breaks down, which is kind of crazy to think about. DKA management. The most important thing is suspecting it and diagnosing it. And so really it's, folks who are taking care in the pre-hospital setting, getting somewhere and, finding your altered patient or finding the person who's breathing fast and just suspecting, checking a sugar, trying to piece things together. IV fluids and establishing good access is absolutely essential. End tidal monitoring can be helpful as you're kind of tracking all the CO2 being blown off. That's going to be your best hint into the acidosis piece. If someone has a high end tidal, that's a cue for you that they're going to be acidotic. And then again, really mostly because of the potassium piece, but cardiac monitoring and a 12 lead to make sure there's no concerning arrhythmia that you then also need to stabilize here. All right, back to our two patients that I started this whole thing with. The 25-year-old with type 1 diabetes and all these symptoms, the 60-year-old with type 2 diabetes and all these symptoms. I think we can hopefully convincingly all agree that patient 1 is concerning for DKA. They're a known type 1 diabetic, so they can't make insulin. Your glucometer is reading high, so we know that D piece is there, the hyperglycemia is there. They're having these rapid, deep respirations. Let's say I tell you that their end tidal is 75. They have the acidosis piece. And let's say you get that fruity breath smell, so you know they have ketones. But what about patient 2? I'd be curious just to get a couple thoughts in the chat. Do we think patient 2 has DKA? Yes or no? And if someone can give me what patient 2 has, bonus points for you. HHNK is a consideration here. It's not what we're getting set up for. HHNK, typically, you're still going to be hyperglycemic, hyperosmolar, one of those two H's. So it's not what we're getting at for this patient. All right, for the sake of time, I'll spill the beans. But one of the interesting things that's kind of come into light because of some of the medications that we have now is you can actually get this diagnosis that's called euglycemic DKA. And so the K part and the A part are still there, but you don't actually have that hyperglycemia piece. And so it's DKA, but with a sugar less than 200. A couple things that put you at risk for this. One, pregnancy. We actually sometimes will see euglycemic DKA. And part of that is just with the increased urination that happens with pregnancy. Some of that sugar is offloaded. You also are kind of feeding for 2. And so baby sometimes offloads that extra sugar, despite the other pieces of the ketosis and the acidosis very much still there. Decreased caloric intake, heavy alcohol use. This is getting back to I just don't have glycogen stores. And so I don't have enough around to actually be hyperglycemic. But the rest of my body is still not getting insulin. I'm still not getting enough energy. So I become acidotic and make ketones. Pancreatitis, similarly, comes from a place of I'm not able to produce insulin and I don't have stores built up. But really what we're working down towards is these SGLT2 inhibitors, which I'm going to call danger drug number 2 that I want you to kind of keep in the back of your mind when you look at a folks med list. So it ends in this gliflozin name. The two most common that we see around right now are empagliflozin and dapagliflozin. These are Jardiance and Farxiga. Farxiga, I feel like I see commercials on TV for. Has like some catchy jingle. Jardiance is great for both diabetes. It also has a lot of data for use in heart failure. So we're seeing more and more folks who are on Jardiance who either have diabetes or don't. Lots of great data behind these drugs. But what's happening is they block sugar from being absorbed in the kidneys. And so the SGLT2 inhibitor at the level of the pancreas says decrease the amount of insulin that's released, increase the glucagon that's released. So you overall are then producing from the fat tissue, breaking down, making ketones. Great, fine. But the big piece is these SGLT2s come over to the kidneys and tell the kidneys to just get rid of excess sugar, get rid of excess sugar. It's one of the reasons it works great as a diabetes medication, is your body just dumps excess sugar out in the urine. But this then becomes the sneaky piece, because the person who otherwise would have DKA with a high blood sugar, they won't have a high blood sugar because they're peeing out all their extra sugar. So the big thing here is if you find someone who's on one of these medications, you're like, gosh, this person looks really sick. They're having that fast, deep Kussmaul breathing. Their breath smells fruity to me, but their sugar's only 100. Like, this can't be DKA. I'm here to tell you that it absolutely can be DKA. And every couple months, we end up getting a case between kind of the ED or the ICU of a missed or delayed diagnosis of this that unfortunately can lead to some bad outcomes. So really important to keep these in the back of your mind. Big bonus points if you roll in and tell me, hey, doc, they're on this medication. I'm worried about euglycemic DKA. Big bonus points there. All right, let's talk about kiddos again, more specifically. You have an 8-year-old, has no known medical problems. You just get called because they're lethargic. Here's your vitals. They're a little tacky, a low normal blood pressure for an 8-year-old, a little tachypnic. Any quick thoughts in the chat of what you want to check or what you're worried about? With the giant asterisk that this whole talk is about diabetes and DKA. So a blood sugar should absolutely be checked here. I gave you 5 vital signs. Like I said earlier, really glucose in my mind is the 6th vital sign. I always have Ray Williams, one of our pediatric EM docs. Her voice is in my head all the time that glucose is the 6th vital sign. So you check a sugar on this kid. It's undetectably high. You check for ketones. They have them. You check their pH. They're acidotic. Not uncommon at all that the first presentation for someone having diabetes is DKA, because they don't get caught in a place where their sugar's high. They don't get caught early enough to start insulin. So they progress to DKA, and then when they're sick enough is when they come in. And so just having on your radar that the lethargic kid, the kid that's not eating, otherwise can't explain a change in a kid, absolutely checking a blood sugar, because we do not want to miss DKA in these kiddos. All right, one more patient to look at. You have a 28-year-old, got called for a well-being check. You find them laying in bed unresponsive. You see this thing here. It's wet kind of around where that white sticker is. Thoughts of what might be going on, what you want to do. Any thoughts of what this is? I assume most folks have seen this, but maybe not all. Yeah, so infusion site. So this is an insulin pump. And there are a couple different looks of how they will appear, but kind of similar idea. It's usually a little catheter that's in the lower abdomen with usually some sort of a device. Some people keep it in their pocket. Sometimes it's out in the open. But the way these pumps work, it's really this teeny tiny thin cannula that's only very, very superficial in the skin. So really easy for this to slide out, especially if you're sleeping, you roll over. So just be mindful. This is what's actually in there. It's not far at all. And then you have the tubing, and you have anywhere along this process, you can have things go wrong. So you can have the cannulas come out of the skin. You can get a separation of the tubing from the insertion site. The tubing itself can become damaged. You can get a failure of the computer itself. So in this case, we're talking about someone who's probably in DKA because it's all wet around and they're not actually getting their insulin. The other extreme, though, you might get someone that is persistently hypoglycemic. And depending the state that you're watching from today, there are some states that have in their protocol to just empirically disconnect an insulin pump. Maine does not have it to just empirically disconnect, but it is in the devices section to call medical control to talk about a device if you think a device is playing in. So you give us a call, and depending where you're at and depending on what the person looks like, we may talk about ways to manage or even take the device out of the picture. So just be mindful that, find this, know that this could be playing into your patient's presentation. Something else that's a helpful hint for folks, if you kind of have a undifferentiated patient that can't talk to you, see kind of one of these white circles. Sometimes it looks like more of a little oblong oval. Again, for the sake of time, so this is a continuous glucose monitor. And so this gets inserted on the arm typically. And there are a couple ways that these work. There are some that are just a continuous input into like a phone app or a separate device. There are others that you have to like tap the phone or tap a device to read the blood sugar. But these are in place for sometimes 2-3 weeks at a time before being swapped out, but just getting constant glucose readings. A couple things to be mindful of here. One, like I said, just to recognize them. It's a good hint for you of what your patient's underlying diseases might be. And then beyond that, patients might just check their sugar for you and say, look, my sugar is 200. It's not my sugar. I would advocate you should still check a sugar with your own glucometer also, because you don't want to just exclude a possible failure of this device. And then it gets really interesting. There are some closed loop circuits where someone will have a continuous glucose monitor and an insulin pump, and the two talk to each other. And so the insulin pump will start to adjust itself if someone starts to have a higher sugar on their continuous monitor. And there are ways that system also goes wrong. It's not common. I mean, the number of people that have these systems versus the times that there are complications is very small. But something, again, to be mindful of, that these devices are fantastic. They are absolutely game-changing for folks with diabetes. At the same time, they are an extra piece of the puzzle. Something else can go wrong, something else to be mindful of. Yeah, seeing a couple comments. So they are over the counter now, which is great. Depending on insurance, they are still sometimes cheaper for patients when prescribed. But yeah, there are places where you can just get these yourselves. And yeah, the glucose readings absolutely can be all over the place compared to your own. That kind of gets us nicely into our next slide. I promise that wasn't planted. But the accuracy of glucometers in general. So the FDA, in order to approve a glucometer, interestingly, only has to be within 15 to 20% accuracy of the true value. And so, if you're talking about someone's actual sugar is 100, plus or minus 20% is plus or minus 20. So you're 80 to 120, you're fine. But, if you're talking about 60 to 65, plus or minus 20% is, plus or minus 12 or 15. I mean, you're talking about treatment, not treatment thresholds. And then, yeah, if the device starts to fail and you're even further off. So absolutely, I would say you should always be checking your sugar with your own device. One key kind of little pearl, definitely clean the skin first, but then make sure you're giving full time for that alcohol to dry. And we see this here on the ED too, and have to pick up on it. Don't then wipe the first drop of blood with the alcohol swab. A clean piece of gauze to wipe away that first drop is great to do, because you're worried that then whatever your Lancet is can actually cause hemolysis of those red cells at first. So your glucose reading gets all wonky. But if you wipe it with the alcohol for some of these sensors can also trigger as being sugar. So you're going to get a false read. So just be mindful of how you're using your alcohol swab. And then check with your department, check with the device that you have. Certainly the devices we have here in the ED have to have a regular QC, a quality control done. So it's like a standardized solution that helps make sure the device is staying accurate. So kind of just be familiar with your own devices and make sure you're keeping them as accurate as you can. Because at baseline, they're 15 to 20% variability. But then over time, if you're getting way outside of this, you can be missing some important decisions. Last patient example to give, and then dive into a couple more drugs, and then we'll wrap up. You had a 50-year-old type 2 diabetes with obesity, having some GI symptoms, has some tenderness in the epigastrium and the upper abdomen. This is the med list they give you. Anything jump out for folks as a concerning med or multiple concerning meds that could be playing in to what this person has? Great. Yeah, the semaglutide, metformin, and semaglutide. Sure. And so the metformin is interesting. I did not include metformin in today's talk because, again, there's just only so much you can include in an hour. Metformin, though, can lead to toxicity that can also cause acidosis and liver injury and pancreas injury. But the piece here I was trying to do for the sake of the talk is the semaglutide. And semaglutide, otherwise is known as Ozempic or Wegovy or Rybelsus. So these drugs are absolutely hot all across the country for all sorts of reasons. So you have your GLP-1 agonists, and so glucagon-like peptide. So it's a protein, it's a peptide that's similar to glucagon, which we've been talking about during this last hour. And so it does a couple things. One is it tells the beta cells to release some insulin. It can then also promote at the brain to tell your brain, hey, we're full. It also tells the stomach to slow down its squeezing and slows down your GI motility. So you feel full sooner and you feel full longer. However, one of the biggest risks that we're seeing come out of this drug is an increased risk of acute pancreatitis. So that's the description for this patient here, is that epigastric pain, nausea, vomiting. And as we're trying to tease out where this falls, it seems to be within the first couple of weeks of starting these medications is where this risk seems to be highest. It's a little unclear at this point why that risk is there, but something to be mindful of. Folks, you know, you're getting their history, getting their med list, know that there is this increased risk on these medications that are becoming increasingly prominent. Similar to semaglutide, there's dulaglutide. Trulicity is definitely out there as a big brand name. Victoza, liraglutide is also out there as a big name. So just being mindful that these meds exist, knowing what your patients are on, knowing some of the big things that can happen for them because of those meds. The other one, and this one's also out there, certainly big time, Mounjaro is tirzepatide. It's a combo of a GLP-1 agonist and a GIP agonist. All you need to know there is it's a similar mechanism, so you kind of just double down on all the effects still. So all sorts of meds to know, and can certainly talk a lot more about them. It depends how much pharmacology you want, but let me know. Always happy to talk more. Other measures to be mindful of. So metformin, this person had, brand name is glucophage. It's a biguanide. That's less important to know, but it helps reduce insulin resistance. So it helps make your cells more sensitive to insulin again. You have this family called thiazolidine diones that also similarly help prevent or reduce insulin resistance. These DPP-4 inhibitors, Januvia is the big one that's out there, helps with insulin release after meals. So it helps with that glucose signal to the pancreas and says, hey, we have more sugar. Hey, we just ate. Hey, let's get a good insulin release. Then insulin itself, again, is a whole talk in and of itself. It's not a pre-hospital med, so I went less into it. But you have all sorts of types of insulin to be mindful of. You have your short acting, your long acting, your intermediates. So just being mindful if your patients are on insulin, you can get a sense of when they last had it or how much they had. That can just be really helpful information. One last thing to give a nod to, and then I promise I'm going to wrap up and hopefully squeeze in a couple of questions if they're out there, is looking to the future of, we know diabetes is a problem. We have lots of ways to help manage it, but can we actually cure diabetes? And again, different types, different pathophysiologies. But one of the really hot things right now is looking at a cure for type 1 diabetes, where the problem is our body has attacked those beta cells in the pancreas. Can we actually then give someone beta cells? And so there are two ways that this is being done. You can actually get a islet cell transplant. The first FDA-approved transplant happened just 2 years ago. There was this big NIH trial that showed that 90% of people were able to get to an A1C, which is a measure of, it's similar to blood sugar, but over a longer period of time, less than 7, which is the target of where we want to get someone who's diabetic, without episodes of severe hypoglycemia 1 year after their transplant. Half of the people no longer needed to use insulin. And then at the 2-year mark, 4 out of 10 people still did not need to use insulin. It is a transplant, and so it's not completely risk-free, which is why we're not just going and doing this to everyone. So you need to be on immunosuppressants, which make you at higher risk for infections and such. But really, really cool thing for folks who are just failing insulin and failing other management options is this islet cell transplant. The other thing is just an entire pancreas transplant. One of the things that comes in here is this tends to be connected of getting a combo kidney and pancreas transplant that comes from the same donor. So you have, advanced disease, as we talked earlier, causes your chronic kidney disease. So you get a kidney transplant and a pancreas from the same person. So two really cool things. It's not being done here in Maine anywhere. I think Boston's the closest place that has a couple of places doing it now. But something just really cool. It's out there. So fun to talk about. All right, tying together from today. So things to definitely take away. Diabetes is an insulin problem. Type 1 diabetes, it's a problem with insulin production. Type 2 diabetes is a problem with insulin resistance. Diabetes has been around for thousands of years in terms of being described, but only recently do we actually have treatments for it. Look for these devices. They are great keys, insulin pumps, the glucose monitors. Recognize the hypoglycemia. Use that rule of 50 to help pick how much of what type of thing to give. Know what DKA is, identify it, get fluids going, get someone to care. Have a couple of these extra meds on your screening list of things that, hey, if this is on someone's med list, it's going to catch my interest. Those sulfonylureas, those SGLT2 inhibitors. And then definitely being aware of these GLP-1 and GIPs, Ozempic and all of its cousins, knowing that pancreatitis is a thing, as well as other complications. So that's where I have for today's talk. I have some references here. Eric has dropped some stuff in the chat too, but I will briefly leave up this QR code here. Please give us feedback on how these are going. Like Eric said, I think this is maybe webinar number 9 now. We started these back in May. We're working on getting a whole kind of curriculum over a course of a couple years of covering topics on a somewhat regular basis, really trying to get you as much coverage as we can. Number 11, even better. And so give us some feedback here, topics you want to hear about, things that we can do to make these better. And then our next webinar, Eric dropped into the chat there too, but QR code here to register. It's going to be Thursday, March 13th at 2 p.m. We're going to get a talk from Dr. Jesse Butler, one of our residents, with Dr. Mark Nevin, who's the director of the Northern New England Poison Center. They're going to come up with some toxicology topic. There are a couple being floated around, but I'm going to toxicology talk from the tox experts in just a month from now. But be mindful of people's time. I know we're coming up on the hour mark, but what questions do people have for today?
So, Joe, we've got one question from Eric in the Q&A who asks, what is the current science on Alzheimer's being a relative of diabetes?
So, fantastic question. And there's kind of a twofold component here. One is there's data that's showing as we kind of tease out Alzheimer's, and it's tough. Alzheimer's right now is a post-mortem diagnosis still technically. So actually doing an autopsy, getting brain sample and seeing some of the hallmarks of Alzheimer's, but clinically you can diagnose Alzheimer's. And so you can actually just get brain damage over time from this kind of constant hyperglycemia exposure. And anytime you have a hypoglycemic episode, that also causes brain insult. So you can get kind of this chronic prolonged brain damage from the high and low blood sugars. But then you get into this interesting space, and I left out from today. Really, it's more in the research space with this concept of type 3 diabetes, where there's then this almost feedback loop of sugar causing brain dysfunction and then brain dysfunction leading to issues with sugar regulation. And so, yes, there's thought to be this link between diabetes and a higher risk of Alzheimer's. There's also this, research concept right now of type 3 that's some brain effects then leading to issues with sugar regulation. So definitely more to come in the medical research space, as long as research continues to be funded. But again, I'm not here to make this talk political today. But yeah, absolutely, there's some link. We just don't know the exact details of that link. Other questions that people have?
That's it from the Q&A section. Eric, anything from the chat section?
I see Dave show the QR code. Which one? I have, this is the one to register for the next webinar. And then here was the one for today's eval. There you go.
And the eval is also in the chat if you can tag it. There were no additional questions in the chat. We did post a third link in the chat an idea was submitted by one of our listeners about potentially doing a follow-up Q&A video on any questions that were outstanding. So we've put that final link in there and to allow people to submit a question. And if we have enough, we'll actually Joe and I will get together and do a video, read the questions back and forth and answer them all, and put the video out for everybody. Or if there was a question you just didn't feel got answered, or you didn't think of anything, or it comes to you later, throw it in there and Joe and I will work together and get that question answered for you. Joe, we'd like to thank you again for a great webinar. I'd like to thank everybody else for attending, and I hope you all have a great week.
All right, take care, everyone. Stay safe in the snow.